Thank you for that kind introduction, and I'd like to start out by saying how extremely honoured I am to be invited to give this oration. It's my first visit to India, but I hope it won't be my last. I've learned so many things in the past 3 days since I've been here that I didn't think possible. And I'd like to thank the organisers for arranging the trip, for inviting me, for giving me the pleasure of coming here and speaking to you. And when I was asked to give the Dholakia lecture, I went online to find out as much as possible as I could about this distinguished orthopaedic surgeon from India. And I noticed in the biography of the Fellows of the Royal College of Surgeons of England, they called him the doyen of orthopaedic surgery in India. And in reading the biographical details of this gentleman, it's clear that he's been a leader in so many different aspects of the orthopaedic endeavour in your country, in particular for joint replacement and also for bone healing, which is what I'm going to be talking about now. The biographical outline is on this slide. He was born in Rajkot in Gujarat in 1920, went to St. Xavier's College in Mumbai. So he's educated in this city, came up, got his Bachelor of Medicine, Bachelor of Surgery at Seth GS Medical College and a MS in General Surgery in 1945. He's made a Fellow of the Royal College of Surgeons in Edinburgh. He went to Great Britain to further his training, both at the University of Liverpool, which he seems to have a strong connection, and also in Scotland, hence the Fellow of the Royal College of Surgeons in Edinburgh. Came back, worked at the KEM Hospital, where he's Professor and Chief of Orthopaedic Surgery, and seems to have spent the bulk of his career until he retired at the Bombay Hospital. And he's won so many awards, I didn't even try to list them on a slide. I probably wouldn't have had time to give my own talk because he's been so well recognized by the orthopaedic community, both in India and around the world. But I did pick out a couple of things. He was president of the Indian Orthopaedic Association in 1968, and then president of SICOP in 1978. And I noticed he was made an honorary fellow of the Royal College of Surgeons of England in 1983. Now, I went to that college on sabbatical in 1990, so we've both been at the Royal College of Surgeons in Lincoln's Inn Field in London. So to recognise that connection, I actually wore my Royal College of Surgeons tie today to give the Dholakia lecture. So these are big shoes to fill, so I'll do my best and start off with my background, which, as you heard at the beginning, is in cell and molecular biology. My first degree was in genetics. So when I entered the field of orthopaedic research, I took my genetics with me and started to work on orthopaedic gene therapy. Nobody else was doing this, so it seemed an opportunity to make a unique contribution to the field. And over the years, it's developed into two main areas of interest: arthritis and other joint diseases, and also regenerative medicine, the repair of bone, which I'm going to be talking about for the rest of my talk, as well as other tissues of interest to orthopaedic surgeons. So this is the high-tech, my title is High-Tech and Low-Tech Approaches to Healing Bone. So this is the high-tech approach. And I've been working on this for in excess of 25 years. And just to bring you up to date with what progress has been made in that time, in the context of joint disease, whereas this slide indicates we've been using viruses to put therapeutic genes into the synovial linings of joints, and the genes express therapeutic proteins that are secreted into the joint and make it better. Well, after 25 years of research, there are a few phase 1, phase 2 clinical trials, and I've been involved in some of them. And in August, a company in South Korea, TissueGene, have got approval for a drug, Invosa, based on gene transfer to joints. So after 25 years, we have one product in South Korea and then just a small number of early clinical trials. So it's not quick and it's not easy. And in thinking about how we get research from the laboratory bench into clinical trials and then into patients and improve clinical outcomes, I drew this little heat map. And I've been working, as I said, on gene therapy, so we're on the extreme here of the hard end of translation, of getting things into the clinic, along with people that work with embryonic stem cells, induced pluripotent stem cells, and what have you. And as you go from right to left in this diagram through other types of cells, proteins, and then traditional drugs, it gets easier. If you repurpose an existing drug for a new indication, it's easier again. And the people who work with scaffolds and devices have it the easiest of all. Now, because the more high-tech stuff takes longer and costs more money, it makes it difficult to get it into the clinic. So if you're talking about a device, you're probably going to spend 3 to 5 years and a few million US dollars to get it to the patient. If you're working in gene therapy, it's talking more in decades, and you're talking in hundreds of millions of dollars. So it's not quick or easy. And this is a very good opportunity for me to introduce you to the world's most expensive drug. And this is called Glybera. It's a gene therapy for a rare genetic disease of lipoprotein lipase deficiency, and the price is 1 million euros per treatment, which rounds up to 1.2 million US dollars. And it's clear this isn't of any good to the majority of patients. And in fact, I hear that the company Unicure that produced this have only sold one dose, and they're not going to market it any further. So here's decades of work, millions of dollars, that really have come up with something flashy that nobody's going to use. And you can use gene therapy to heal bones. As I said, our other half of the lab works on regenerative medicine. This is a rat femur where we've made a 5 millimeter defect. So that's critical size, so that's not going to heal spontaneously. If you leave it for 8 weeks, there's still a gap there. If you use an adenovirus to put in a gene that makes bone morphogenetic protein 2, it heals very nicely. And we've done a lot of research in this area, but we're still stuck with the problem of how do we get through this translational process, get it into the clinic in an expeditious manner. So in this frame of mind, I've been interested in switching from the extreme hard end to the easier end of this spectrum, and working more with devices where the cost and the timelines are quicker. And putting this into practice started when this young lady, Vida Glack, came to talk to me and asked if she could do her PhD with me. Now, Vida is an engineer, or was an engineer, in the lab I had at Harvard when I was there. And I said to her, well, you're an engineer and I don't know much about engineering, but I'm a biologist and you don't know much about biology. So maybe together we can use some of the animal models we've developed in bone healing and see if we can make the bones heal better using a combination of biology and mechanics. And so Vida's PhD thesis was devoted to studying the effects of the mechanical environment on the healing of segmental defects in the rat femur. Now, as you all know, when a bone fractures, it heals through various stages. It first forms a hematoma with granulation tissue that gives way to cartilage, which then undergoes the process of endochondral ossification to form a bony callus that remodels and gives you back the original bone. And the question that Vida addressed is whether this process can be accelerated and whether you get better outcome if you manipulate the mechanical environment of the bone. Now, we figured it would, and it's not a novel idea. It's been around for at least a century, since Julius Wolff in Berlin developed Wolff's law, which encapsulated the fact that bone is very responsive to mechanical forces. You can have resorption or osteogenesis by manipulating those forces. So Vida was able to use this as part of her PhD, and the process that preceded this is that of dynamization, which I know has been mentioned in the previous session, but basically the concept being that the early stages of bone healing needed to be protected when you had this fragile hematoma and then a soft callus that couldn't bear weight, and that once you got past that and you were forming bone, the bone now needed mechanical stimulation, so you'd allow much more load, much more axial movement across the healing defect. And this goes back at least 35 years to the time of Dr. De Bastiani and his colleagues at the University of Verona in Italy. This is a paper published in the Journal of Bone and Joint Surgery, the British version in 1984, where he describes an external fixator which allows for axial dynamization by the tightness of this screw. So when it's loose, there's a lot of telescoping of the device and you get axial motion, and when it's not, you don't. It's stiff. And so at the first radiologic indication of periosteal callus at 3 weeks, they undid the screw, allowed dynamization to occur, and in this paper presented some pretty impressive rates of healing in difficult cases. Now, we had a slightly different take on this because we'd observed in our rat models that if the fixation wasn't stiff enough, we got an accelerated formation of cartilage. Now, in another talk, which I'm obviously not going to give today, we look a lot at cartilage repair and chondrogenesis, cartilage formation, and we're aware of how sensitive it is to mechanical forces. And in the setting such as this of a fracture or a defect, the motion within that defect accelerates the deposition of cartilage dramatically. So we thought instead of having a stiff fixation, which in normal forward dynamization is there to protect the forming delicate tissues, we would actually do the opposite and have these axially loose so that we promote a rapid formation of cartilage. And it's only at the stage that the cartilage turns to bone that you need stiffness, because any movement disrupts the invagination, the ingrowth of the vascular system, which is essential for the endochondral process. And the next slide just shows some rat tissue where when this is fixed appropriately and this had been a defect which is now healed, when we have loose fixation, we get this rapid formation of cartilage, which is stained red here with the stain safranin O. So we came up with the concept of reverse dynamization, where the conversion of the initial hematoma after an injury into cartilage, soft callus, would be enhanced by loose fixation, and then the conversion of that cartilaginous plug into new woven bone would be accelerated by stiff fixation. And we call this reverse dynamization simply because it's the other way around from the way we normally think about dynamization, which is stiff going to loose. So to implement this, we made contact with an engineer called Romano Mattis, who's at the AO Research Institute in Davos, and is very gifted at making small, precise fixators for rodents, rats and mice, and sort of brings the same precision that Swiss watchmakers bring to watches, he brings to fixators. And he designed for us a customized external fixator where we could vary the stiffness of the fixator by the thickness of this bar here. And he developed 3 different thicknesses of these things, which when we tested them in a material testing device, we had a low stiffness bar, which had about 114 newtons per millimeter of stiffness, a medium stiffness one that was 185 millimeters per newton, and then a stiff one, high stiffness, of 254. Romano also developed for us a very ingenious way of forming these defects that gave precisely a 5mm defect in precisely the same place each time. So there was a saw guide. He came up with a jig to hold the material as we were putting it in place. And then you'd end up by using a giggly saw to take out the 5mm of bone, and you end up with a very nice system which we could do very precise work in a reproducible fashion. And so we went to our rat model and set up 4 different groups of animals where the 5mm femoral defect was either fixed loosely over the low stiffness fixator, the high one at 254 newtons per millimeter, and the medium stiffness in between, and then a group where we had reverse dynamization, where we started off with the low stiffness, and at 7 days, which in this model is when you first start to see evidence that you're getting cartilage and early signs of calcification, we switched, changed the bar on the external fixator, so now it was of high stiffness, and we saw what we could get. All of these animals got BMP2 because a 5mm defect won't do anything at all unless you give it an osteogenic stimulus of that nature. What we saw was quite remarkable because under conditions of low stiffness at 8 weeks, this is the top panels are stained with hematoxin eosin. Down here it's safranin O and fast green. The safranin O stains cartilage red. At low stiffness, there was a large amount of disorganized tissue. At the medium stiffness, there was more bone, but there were these big cysts in the middle, which we don't quite understand, but just note that their presence. And at high stiffness, the healing was incomplete, and we saw areas where there's cartilage that hadn't turned to bone. If we did the reverse dynamization, it was quite remarkable. There was good cortication. The marrow elements are reforming. This is a pinhole, it's not a defect. And the dimensions of the new formed area in the femur matched nicely the original one. They didn't have these big nebulous calluses around them. And we could confirm this by microcomputed tomography. So you can see here in the reverse dynamization, we're getting good cortication, good reformation of elements in the marrow. And if you use a single stiffness all the time, whether it's loose or whether it's stiff, you fail to get equally proficient bone formation. And if you look in cross-section, you see much the same thing, that when you use reverse dynamization, you reform the contours of the femur very nicely. There's not too much bone persisting in the canal, and under other conditions, you get other things forming, especially in this middle stiffness where we're getting these big cysts. As I said, we don't really understand them. Now, the 5mm defect in the rat femur that I've been talking to up to now, as I said, it doesn't heal spontaneously. So before we can study anything, we have to put BMP2. So we wanted to know whether this was generalizable to different types of defect, including ones that didn't need to be kick-started with BMP2. So we went to a 1mm osteotomy in the rat, which heals spontaneously. We don't need to add anything. And we, again, applied our different stiffnesses. And what you see here is shown in cross-section micro-CT in the first column. These two are sagittal sections micro-CT. And this is a section stained histologically with toluidine blue. And what you see is what you see here, that under conditions of stiff fixation, you form bone, but the cortices aren't complete. There's elements still in the marrow cavity, and on histology, you still see the fracture line. And if you have it flexible the whole time, you see much the same thing, except there's more of it, basically. If you start to dynamize after, or start to stiffen, this is reverse dynamize. So if you go 3 days under flexible conditions and then impose a stiff regimen, you immediately start to see an improvement, which is optimal at 7 days. So if you let the animal go 7 days under flexible fixation and then convert it to a stiff fixator, you see no residual fracture line you're getting good cortication and the marrow elements are clear. And also on cross-section you see that it looks much more like the native femur. And if you wait 21 days before you stiffen, that's too long and it starts to deteriorate again. So again, as with the critical size defect, the healing defect seems to be obeying the same pattern of behavior under reverse dynamization. So the conclusions from what we've done in the rats are as follows, that we can accelerate the healing of critical size and subcritical size defects using reverse dynamization. What I haven't shown you, but we've done in separate studies, is if you use reverse dynamization, you need less BMP2 to heal a critical size defect, so there's a sparing effect. And if we look at the nature of the reformed bone, that we get advanced cortication, reduced callus size trabeculae, contours are improved, marrow elements form better, and again, I haven't shown you, but the mechanical strength improves. So we're quite impressed by what this relatively simple manipulation can do in the context of accelerating the healing of bone. And now what we're trying to do is bring this into clinical use, and in particular to design and manufacture an adjustable external fixator that is affordable. Remember when I was talking about gene therapy at the beginning of my talk, one of the issues is its cost, and if we're going to treat something as common as a fracture, we're going to have to make it affordable to the masses, as it were. Simple, effective, practical, and also straightforward regulatory path. Didn't want to get tied up for eons with the regulatory bodies to go back to the drawing board and keep them happy. Now, at this point, I made contact with two colleagues, Dr. Stephen Brezina and Dr. Slobodan Tepic, who have a company called Akeso, and they have a booth out in the exhibit area, and Dr. Brezina's here and available to answer questions on this. But they're two bioengineers who've been collaborating on this project, and they've designed this external fixator that we think could be taken into clinical use in human patients. And it basically contains two separable bars that fit together and enable screws to pass through. And the key thing about it is that there are two types of screw, ones that go into the bone vertically at 90 degrees, which provide very little in the way of axial stiffness, and then these angled pins that go in and can be locked. And when they're locked, they provide the axial stiffness, and when they're not locked, they don't. So you can dynamize quite readily simply by locking and unlocking these diagonal screws. So the idea is that they would go in the unlocked position in the fresh fracture, and at about day 14, when the cartilage is formed and you're wanting now to have accelerated endochondral ossification, you lock the angled pins, stiffen the device, and accelerate the healing. We've done some preliminary work in sheep using this. So this is a sheep tibia. We made an osteotomy here, cadaverically, and put the fixator on, and this is what it looks like when it's in place. This early design had the angled pins in this position. We've since changed that. But we've put this through considerable mechanical testing and through all sorts of cycles of loading that are way beyond what a human being might be expected to impose. And the device holds up very well indeed, and we've been able to extract a lot of sophisticated mechanical data about the device and come up with some finite element analyses as well that enable the structures to be analyzed in greater detail. We've also put some on living sheep. So this is Dr. De La Vega Amador, who's from Colombia in South America, who's in between medical school and the orthopedic residency. This is Mr. Nicholas Quirk, who's an engineer from Australia who's doing his master's degree working on this project. And this is an intraoperative picture in the sheep where the device has been put on the sheep's tibia. This is what it looks like when it's in place. Again, the diagonal screws are put in this fashion, in this particular formulation. And we've been able to get some in vivo information about how it behaves, and everything looks pretty tight, so that's encouraging. And the final configuration that you'll see if you go to the ACASO booth out there is in this form, where the diagonal screws are now at the outside in between two of the 90 degrees vertical screws, and there's the frame that holds it all together. And it comes as a kit. These are 5mm screws that are commonly used for external fixators. The novelty lies with the bar and the way in which it's assembled to give changes in axial stiffness appropriate to the need. So with that, I will just thank my collaborators. I've mentioned them all by name as we've gone through the talk. The only ones I haven't mentioned are Andrew Torreson, who's the manager of the biomechanics laboratory core at Mayo Clinic, who's worked on this, and Mark Varus, who until recently was chief of orthopedic trauma at Mass General Hospital in Boston, and he's now the chair of orthopedic surgery at Cedars-Sinai Medical Center in Los Angeles. I'd like to thank the funding sources, which is the AO Foundation, the National Institutes of Health, and also the US military, the Department of Defense, who are clearly interested in different new and better ways to heal bones. And I thank you all for your attention. Thank you very much.